These few words are intended to introduce Dr. George Depasquale's interview, which will follow. As you will hear, leprosy was endemic in Malta since ancient times. At the start of the 1970s, there were more than 200 known leprosy patients registered in Malta, with an annual incidence of about 10 new cases every year. Unfortunately, the treatment that was available at the time could only at best control the disease, but not cure it. And at this time, it was proposed to use multiple drugs, so-called multi-drug therapy, to improve the efficacy of treatment. This approach was trialed in Malta starting in June 1972. And it was called the Malta Leprosy Elimination Project. It was a program supported by the Sovereign Military Order of Malta and the German Leprosy Relief Association. George did most of the clinical work in this project and followed patients meticulously for many years. It is fair to say that it is largely to his credit that the program was so successful, and subsequently, and as a direct result of this program, multi-drug therapy became established as the standard treatment for leprosy and has remained so to date. Literally millions of patients throughout the world have benefited from this important breakthrough. On a personal note, I got to know George when I started dermatology in 1989, and more closely later when I became president of the Maltese Association of Dermatology and Venereology, and George was our long-standing treasurer. George was a wonderful person, always ethical, methodical, kind, and unassuming. Sadly, he passed away after a short illness, surrounded by his loving family, on the 7th of March 2024, aged 80 years. Although George knew he only had a few months to live, he generously, and so typically, insisted on giving this interview to document his experiences. He's fondly remembered by his patients and his colleagues.
Leprosy is a disease caused by a mycobacterium, similar to the mycobacterium that causes tuberculosis. And I mentioned this in relation to the treatment and rationale. But the actual organism is Mycobacterium leprae. Now, this mycobacterium attacks mainly nerves, but we have manifestations in the skin. To correct a misconception, a great misconception, leprosy does not cause fingers to drop off or other parts of the body to drop off. The patient, when pictured, might seem to have been, but what happens actually is the erosion of bones. In actual fact, sometimes you can see a palm without any fingers, but nails sticking out of the end. That's to correct a great misnomer. Secondly, it's the least infectious of infectious diseases. We consider that roughly 90% of the population has a genetically inherited resistance to the mycobacterium. So, the great fear of infection should be put away with. That's obviously the disease can affect multiple organs, most commonly the eyes. It can cause blindness. It causes disfigurement of the face with saddle nose. In lepromatous patients, rather large infiltrated earlobes, and really elongated. I've seen cases where the ears were twice the normal size. And obviously these disfigurements tended to create a certain stigma. With regard to the position of leprosy in Malta, we know that leprosy has been endemic since the time of the Knights. The law of segregation that luckily was repealed in 1953 did nothing to really help the patients, but created an even greater stigma for the population outside. Luckily, in 1953, Sir Paul Boffa's intervention abolished the law of segregation, so the patients who were incarcerated, we could say, in the leprosaria were allowed to go back home and have outpatient treatment. At the time, in 1972, we had an incidence of new cases of roughly 10 per annum. When we started the program, we tried to treat all patients, and we had on our books something like 260. As I said, mainly our problem was the stigma rather than the disease, because the disease we could cure. Prior to the start of the eradication program, the only treatment available was treatment for life by fortnightly injections of Depsone. That had to be carried out either in the few patients that were still at the leprosaria, or attending outpatients at the skin department in St. Luke's at that time, or the Gozo Clinic. I qualified as a medical doctor in 1969. So in 1972, when I was asked to join the program, I was relatively a very young doctor. Obviously, I was asked because I was attending the dermatological unit quite regularly, and obviously I took up the challenge in order to try to help these poor leprosy patients who, as I said, were suffering from great stigma. Let's put it this way. The scientific brains behind the whole project was Professor Enno Frerksen from the Borsel Research Institute. He was mainly an expert in tuberculosis. However, he took an interest in leprosy and reasoned that leprosy, being a mycobacterium like tuberculosis, should be treated with multiple drug therapy rather than monotherapy. The monotherapy that I mentioned earlier that our patients were receiving is what we call a bacteriostatic drug, and that is why it had to be taken for life. And in his labs, he devised combinations that could destroy the mycobacterium in vivo, and in that way we could treat patients for a much shorter time and follow them for as long as necessary. We managed to treat our patients. Some patients who were bacteriologically negative at the start were still treated for 5 months, just to make sure that if there were any residual mycobacteria, these would be destroyed. Most of the patients were treated for an average of 2 years, and the whole idea of doing this program in Malta was that, being an island, people tended to rather stay in one place rather than just move about, as would be the case, say, in any center in Africa. We managed to examine the patients every fortnight and administer the medication ourselves. When I say ourselves, this was myself and the late Dr. Edgar Bonici. We took smears from every patient every fortnight initially, and a biopsy every month. After termination of therapy, obviously, we spaced out the visits and the frequency of smears and biopsy. But we are proud to say that we managed to keep on following up, I would say 90% of the patients, for as long as 17 years, which is rather remarkable. Obviously, this was due to the great cooperation that we found from patients. I would say that there had already been a request to WHO for some program regarding leprosy to be done in Malta. At that time, the Sovereign Military Order of St. John got interested in helping out and approached the German Leprosy Relief Association to cooperate. And this is why Professor Ferguson's program actually precipitated to Malta. Obviously, it was a WHO sponsored program, financed mainly by the Sovereign Military Order and the German Leprosy Relief Association. When Professor Ferguson started the program, he stayed on the island for 2 months in order to ensure that he managed to see all the patients that could be examined. And after that, he visited Malta on a regular basis, I would say on a 6-monthly basis, sometimes for a fortnight, sometimes for a week. Obviously, later on, because of his advancing age, visits started becoming less frequent. But obviously, all the smears and biopsies that we carried out were examined at the Borstal Research Institute. And the results from a bacteriological count were also determined at the institute. And obviously, depending on the results, treatment was either continued or terminated. All patients were treated. All patients were examined. A few obviously were bacteriologically negative and were treated for 5 months. All the rest of the patients on our records were treated, obviously, except for a couple, I would say 3 or 4, who refused all form of treatment. The patients realized that the multiple drug regimen made a big difference, and this is what most of the patients reported. They felt that the treatment was now being effective. You can realize that the combination is a bactericidal form of drug, and being a fixed combination, we treated all patients with rifampicin, a combination of rifampicin, isoniazid, prothionamide, and Dapsone. And that was quite a hefty dose to give. Funnily enough, we administered this treatment on a 6-day regimen, with Sunday being left without any treatment. The idea was that if you got any cumulative effects from the drugs, obviously that 1 day of abstinence would control it. Obviously, especially rifampicin tends to have an effect, a toxic effect on the liver. So in some patients, we did notice some liver changes. However, funnily enough, these liver changes never reached a stage that treatment had to be stopped. I wouldn't say interesting, I would say disturbing. I had patients who, because of the stigma, did not inform even their immediate relatives. I had patients coming up saying, listen, rather not patients in the sense that relatives of patients, coming up saying, listen, we've just discovered that our father or our mother had suffered from leprosy. Can you please examine us in order to put our minds at rest? That is the extent of the stigma that the disease had. I would say our patients suffered more from the stigma rather than the disease itself, despite the fact that some of the very old cases had mutilations and severe complications from the disease that had been partially treated, I would say, over the years. In actual fact, it's interesting because certain types of reactions that you get in leprosy, where you get a flare, what we call a flare-up, are due to the destruction of the mycobacterium. It is a sort of anaphylactic reaction to the breakdown products of the mycobacterium itself. Unfortunately, those are episodes that can be disturbing and painful for the patients. We used to treat these reactions mainly very well controlled with thalidomide, which we had to keep under lock and key, obviously, for its gizmo. In rare cases, we had to resort to steroids. But I would say most of the reactions were controlled by just thalidomide. Well, Gozo wasn't forgotten. We used to go up to Gozo to examine patients every Thursday, once a week, examine all patients, distribute the medications for people who were on medication, obviously do the same examinations as we carried out here in Malta. Besides, we had to do certain house visits because certain patients were housebound. And those I had to do on my own usually. And patients were really grateful that we could see them at their home, sometimes even very late at night, in order not to attract any attention of neighbors being visited by myself, known to be treating leprosy. Most patients would refer to their disease as the disease and not leprosy or Hansen's disease. Definitely, they would not refer to the disease with a small t's terminology of Chtim. Unfortunately, even though I myself and Dr. Bonici were not government employees at the time, but were actually carrying out the program in government centers, we were asked to sign the same declaration that the Maltese doctors working in government service were asked to sign at the time. That is, that they would bind themselves to carry out any work that the chief government medical officer at the time dictated. Obviously, in our case, we could not accept, first of all, it really did not make sense for us to do it, because this signature would have had no effect since we were not government employees. And secondly, it would have seemed to be undermining our medical colleagues, and as a consequence, we were not allowed to carry on with our work in the government centers. Despite this, we carried on doing house visits and seeing the patients in that way. Luckily, by that time, the number of patients who were on treatment had actually decreased. Following the intervention of the ambassador of the sovereign military order, government reached an agreement that we could carry on seeing patients in another site, government site, but not within the government hospitals. So after I would say, a short break of 2 or 3 months, we were back seeing patients in our more or less regular fashion. Well, we started seeing patients in the outpatients, the dermatological outpatients, that at that time were still within the grounds of St. Luke's Hospital. At that time, inpatients were already at Boffa Hospital, which at that time was known as KG5. In Gozo, we used to see patients first at the Gozo Hospital in St. Francis Square, the old hospital that is now the ministry, I believe, of Gozo, and subsequently in the Gozo Hospital, the new Gozo Hospital. As I said, we also visited initially the patients that were still in the leprosarium, but these patients were after, if I'm not mistaken, in 1974, moved to one-bedroom flatlets in Tal Farha, limits of Gargour. Okay, so again, once a week, I used to visit those patients there. I think one of the major successes of the program was the amount of time we could devote to each patient and to discuss not just the disease, but also the social impact of it. I think if you're doing this type of program, you definitely need the full cooperation of the patient, which I must say we did have. I am satisfied that I will be leaving this world and leaving Malta in a better situation than it was when I graduated, from the point of view of having eradicated leprosy. Obviously, the fact that we've eradicated leprosy does not mean that we have to forget all about it, because unfortunately, especially with the influx of foreigners into the country, especially from third world countries, there is always the risk that we would also be importing leprosy either in a dormant form, because leprosy, the incubation of leprosy can take up to decades at times. And that way, unless we're on the lookout, we might start an endemic focus again.